Welcome back to the Vanderbilt Eye Institute's Audiovisual Atlas of Retinal Diseases. In this chapter, we will be talking about angioid streaks. The introductory session, we will talk about the clinical appearance, a brief word on the histopathology, and then go through several examples of angioid streaks, and then follow up with some treatment and management guidelines. Angioid streaks appear clinically as reddish lines, either circumferentially around the nerve and/or as radiating lines extending from the nerve peripherally. Patients who have pseudoxanthoma elasticum can have a particular look to the temporal periphery known as peau d'orange or orange skin. Pathologically, the streaks are breaks or dehiscences of Bruch's membrane. Choroidal neovascular membranes, unfortunately, are a frequent and common complication. The most common systemic diseases associated with angioid streaks are pseudoxanthoma elasticum, Ehlers-Danlos, and sickle cell disease. Here is a classic appearance of a patient who has angioid streaks and also a subretinal neovascular membrane. The double red-brown arrows point to the circumferential streak around the optic nerve. The two single arrows point to some fairly obvious streaks superiorly and nasally. The red arrow points the subretinal neovascular membrane. Here is a red-free photograph of the same patient. The angioid streaks can be seen much easily with the dark lines. Just in case you missed it on the colored photograph, you can now see an angioid streak extending from the nerve at 6 o'clock to the inferior periphery. You can also see the subretinal neovascular membrane quite easily in the nasal macula. Here is a mid-face photograph of that patient. The angioid streaks are hyperfluorescent because either the pigment in the pigment epithelium is attenuated or the RPE is gone over the streaks, and therefore the streaks show up as window defects. The neovascular membrane is hyperfluorescent from leakage from the vessels. Now a brief word on the ocular treatment. In years past, the argon laser was used to cauterize the vessels just as we did for any choroidal neovascular complex, whether it is from macular degeneration or a subretinal neovascular membrane after histo or a choroidal rupture. However, because the breaks in angioid streaks are not focal and they're widespread, recurrences were very common. There's a very, very short time when some people tried submacular membrane removal. However, most of these cases came back with a very aggressive net and patients lost a tremendous amount of vision. So that was not done hardly at all. So when photodynamic therapy became available, that was the treatment of choice. And it could stop the progression of the neovascular complex, but it often led to central atrophy, as we will see in the next example. At this time, anti-VEGF injections are the mainstay to treatment. This 64-year-old female was referred to me many years ago because she had blurred vision in the left eye for 1 month. The vision in the right eye was 20/20 and the left eye 20/200. On this clinical photograph, which was taken when she first came in, you can see one angioid streak extending from the nerve almost to the fovea. There's another circumferential streak nasal to the nerve, and there are two streaks, one above and one at 4 o'clock, which have some atrophy. Here is the clinical picture and angiogram of that patient on her first visit. You can see the angioid streaks coming off of the nerve and a circular pattern of subretinal hemorrhaging. The subretinal hemorrhaging is surrounding a neovascular complex, which you can see in the mid-phase photograph above and the later phase down below. The angioid streaks are also seen as hyperfluorescent lines extending from the nerve. This patient did receive photodynamic therapy because she came to my office before the era of anti-VEGF treatment. This photograph was taken 1 year after the photodynamic therapy. Again, you can see the angioid streaks quite well, and in the macula, she's beginning to develop some atrophy. Her vision had dropped a bit from 2200 to 2400, but over that year between the photodynamic therapy and this photograph, she'd had no further medical intervention of any kind. And here are two more clinical photographs of that same patient. On the left, the photograph was taken 7 years after the photodynamic therapy. Her vision at that time was still stable at about 2400. However, look at the macula and you can see there has been progressive atrophy of the pigment epithelium and the choriocapillaris. However, also during the 7 years, she required no medical treatment or injections of any kind. 8 years later, the vision had dropped and it was down to recorded as 200, but she also had a moderate nuclear cataract. And then you can also see some more pigment clumping and migration in the central macula. So here is the initially asymptomatic eye. The photograph on the left is the baseline and when the vision is 20/20. Within several years, however, she developed a choroidal neovascular membrane in the right eye. And she's now had monthly injections for close to 10 years, and the vision's remaining at about 20/70. At one time, we tried to extend out to 6 or 8 weeks, but she rebled, and she's on a every month basis, and she's been that way for at least 6 to 7 years. You can see some more atrophy in the macula, and the streaks superiorly and infranasally from the nerve are wider and much more atrophic than when she first presented. Now, a final word on management. Because about half of the patients will have a systemic disease, it is important for you to contact their physician and alert them to your findings. Also, because most patients will develop choroidal neovascular membranes by the mid-40s or 50s, and oftentimes bilateral, they do need careful and close monitoring. Also, counsel them on possible effects of minor ocular trauma and possible GI bleeding, especially if they have pseudoxanthoma elasticum. Minor ocular trauma, which most eyeballs can sustain without any problem, do have a tendency to rupture the angioid streaks and the Briggs and Burke membrane more, and they will develop further posterior pole problems. So you do need to give them precautions regarding trauma.